Good morning, and welcome to the Bipartisan Policy Center's webinar on the integration of behavioral health and primary health care. I'm Bill Hoagland, a Senior Vice President here at the Bipartisan Policy Center, and I have the very distinct pleasure of working with our health team on policies to improve healthcare delivered to all Americans and at reduced cost. We know that over the past year, during the pandemic, anxiety and depression in adults has almost quadrupled. Drug overdose deaths are at a record high. And sadly, very sadly, one quarter of all young adults have seriously considered suicide. We also know that many of these people and these young people are not getting treatment. And even before the pandemic, more than half of the Americans with a mental health condition and nearly 90% with substance use disorder did not receive treatment. To a large extent, this is because our behavioral health care system does not have the capacity to serve everyone who needs treatment. Primary care providers pick up some of that slack, but they simply do not have the training, the resources, the guidance, or the staff to deliver integrated physical and behavioral health care services. Therefore, BPC last year launched a behavioral health integration task force to develop policy recommendations that we think would advance the integration of physical health, substance use, and mental health services. We know from research that the integrated care that delivers a lot more patient-centered, it's a centered policy model that can be both cost-effective and provide increased access to treatment, reduce health disparities, and improve patient outcomes. So we brought together a very impressive group of task force members with 4 outstanding co-chairs. Those co-chairs are former Senator John Sununu of New Hampshire, former Congressman Patrick Kennedy of Rhode Island, and the founder of the Kennedy Forum, Sheila Burke, a fellow here at BPC and chair of government relations and public policy at Baker, Donaldson, Berman, and Berkowitz, and Richard Frank, distinguished professor of health economics at Harvard University. And they were joined on the task force by former Surgeon General Regina Benjamin, Kenna Chick, who is former president of the Project Lighthouse Peer Support System, Charles Curry, former administrator of Substance Abuse and Mental Health Services Administration, SAMHSA, Nella Domenici, CFO of Datamir and former CFO of Bridgewater Associates, former Congressman Eric Paulson of Minnesota, former Congressman and Governor Ted Strickland of Ohio, and last but certainly not least, Vicki Wachino, former Deputy Administrator at the Center for Medicare and Medicaid Services. We're fortunate many of them will be able to join us today. Now, this report that we're issuing today is the culmination of over a year's worth of hard work by the task force, the co-chairs, and most importantly, the BPC health staff here led brilliantly by Marilyn Serafini, Director of Health Project. Time does not permit me to mention all that BPC staff that worked on this project, but you will find them listed prominently in the report. We also contracted with Health Management Associates to assess the cost of the various recommendations put forth by the task force. While they analyzed only a certain recommendations that we were able to analyze, they found that we estimate that maybe these recommendations, if implemented, would provide additional benefits to over 1 million individuals out there. And these recommendations would cost the federal government of about $2 billion over 10 years, which includes about $7 billion in increased federal spending, but $5 billion in savings coming forth. We truly believe this report provides a bipartisan roadmap for the integrating primary and behavioral health care to the betterment of all. Finally, on a personal note, I had the honor and pleasure as a Senate staffer for many years to work with Senator Pete Domenici, a Republican from New Mexico. Against great odds, Senator Domenici reached out to his Democratic colleagues, Senator Paul Wellstone of Minnesota and Senator Edward Kennedy of Massachusetts, to pass that landmark federal legislation the Mental Health Parity and Addiction Equity Act of 2008. I am so happy and so proud that the daughter and son, Nella Domenici and Patrick Kennedy, have continued their father's legacy of addressing these challenging issues today by serving on this BPC task force. So onward. Before turning to our panel discussions, we have two short pre-recorded remarks from Ben Miller with Wellbeing Trust and Brandon Skidmore with the Sunflower Foundation. These two organizations, Wellbeing Trust and the Sunflower Foundation, along with New York Community Trust, graciously provided support for this work, for which we would not have been able to do without. So thank you, Ben and Brandon, and we'll do the videos now.
Thank you, Bill. It's been our great pleasure to jointly sponsor this work with our friends at the Sunflower Foundation, work you're going to hear about today. For those who are not familiar with Wellbeing Trust, we are a national foundation focused on advancing the mental, social, and spiritual health of the nation. We're just over 5 years old as a foundation, so in our adolescence, and we were started by the Providence Health System in service to working on ways that we can move the needle for mental health and well-being. And so what an amazing time to be doing the work that we're going to talk about today. This is a unique moment for our country to come face to face with an issue that has been historically ignored. Mental health is all of us. Every person has it. It's the foundation for our health, our core. And yet we've not developed a system that can take care of it when we need help. We look to the problems, we see fragmentation in how we pay for care, how we deliver, how we treat care, and how we train for care. It all perpetuates a schism, a false dichotomy that science will simply not allow us to continue to believe exists, despite all our structures making us think it does. The solution? Well, you'll hear about it a lot today, as the solution is firmly rooted in integration, bringing mental health and addiction into the fabric of all our redesign. So even in the face of some of the most dire situations many of us have ever faced, there's a reason to have hope. As we'll hear about, there are a variety of strategies that we should pursue to allow for our integration dreams to become a reality. First, a theme that we'll keep coming back to is if we do not bring mental health to the places that where people are, we're going to continue to fail. We've got to figure out a way to pay for this, pay close attention to the data, and stop guessing at what we think is going to happen. We know the direction the country is heading for mental health and addiction. We've seen it in the survey data. It's the wrong one. We also know that integration strategies work, and we should look for ways we can scale and sustain that important work that's been started. So what we do next is on us. Will we continue to watch the marginalization of mental health, the fragmented approaches, or will we integrate and bring mental health to the front and center of any of our discussions where it truly belongs? In one national survey that Wellbeing Trust did with Viacom CBS, we found that 9 out of 10 of voters from both parties said that our elected officials should be doing more for mental health. This truly is a bipartisan issue. Wellbeing Trust will be taking the excellent recommendations from the BPC report and integrating it into our broader policy work, which we call Healing the Nation. Our nation has been in pain. It's been hurting for some time. This is why Wellbeing Trust stands behind the work of BPC, these set of recommendations, and how we can begin to move forward with our healing. Thank you to Marilyn, to Bill, to Mary, to Anita, to Tara, to all the BPC team for such a great product that I hope gets bipartisan traction with our leaders on the Hill. Thank you.
Thank you, Bill and the Bipartisan Policy Center, and for the opportunity to once again work with the Wellbeing Trust. For over 20 years, Sunflower has partnered with safety net organizations across our state to increase access to quality, affordable health care and behavioral health services. In 2012, in an effort to expand access to behavioral health services, Sunflower awarded its first grants to support integrated care. 9 years later, integrated care represents a substantial part of the Foundation's funding portfolio, providing clinics access to funds and resources to better understand and explore this model and to devise staffing plans and infrastructure needed to begin this important work. Sunflower's support for integrated care has been widely available to all community health centers and to community mental health centers in Kansas, but uptake has been especially strong among community health centers and specifically federally qualified health centers and their efforts to augment access to behavioral health services. We know that in Kansas and across the country, more patients seek mental health care in primary care than in any other health system setting. In fact, the vast majority of the patients receiving behavioral health services in our integrated care clinics are patients with no previous mental health diagnosis or treatment history. Integrated care has proven critical to ensuring that more Kansans have access to the right care in the right place and at the right time. But while our clinic partners and their providers persist in this model, they do so not because it's easy or fiscally lucrative, but because it is, in their minds, how care should be delivered. In fact, all of the clinics that Sunflower has funded through its nearly 10-year investment in integrated care have maintained their commitment to this model long after grant funds have ended, a testament to the forward-looking leadership of these organizations and their commitment to the patients they serve. These clinics maintain integrated care despite chronic challenges in locating, hiring, and financially supporting staff long-term, in training mental health and primary care providers not accustomed to working in an integrated model, and in navigating a reimbursement system which is not designed to support providers in delivering whole person care. Sunflower is pleased to partner with the Bipartisan Policy Center and the Wellbeing Trust, and applauds the critical work of the Behavioral Health Integration Task Force. The recommendations that we'll hear more about today will move the system closer to truly supporting whole person care, where clinics and patients can thrive.
Thank you, Ben. Thank you, Brandon. Now I'd want to turn the discussion over to one of our distinguished co-chairs and friend, Sheila Burke, who will discuss with Kenna Chick and BPC Senior Policy Analyst, Anita Burrows, their personal experiences that speak to the clear need for integrated physical and behavioral health care and the recommendations that we are releasing today. Finally, following that discussion, Sheila will welcome our panel, Senator Sununu, Congressman Kennedy, former Surgeon General Regina Benjamin, and Richard Frank to explain the task force recommendations and the rationale for them. And I would like to invite our attendees to submit questions using the Q&A button, and you can also tweet us questions at BPC Bipartisan. Sheila, over to you. You're on mute too.
Thank you, Billy. And let me also thank both Ben and Brandon for their welcoming comments and for their continued support throughout the work that we've had underway over the last year. Without them, we could not have done this. And I think the product hopefully satisfies and addresses many of the issues they raised that we've confronted. In our work over the last year, the task force really tried to break down the fundamental barriers to integration of primary care and behavioral health care. While we didn't agree on everything, as you might imagine is often the case when a group gets together, there was a strong consensus, without a doubt, that the integration provides the opportunity to increase access to care, to improve quality, and to make that care more cost effective, as Billy pointed out in his opening comments. Several states we know have already begun this work and are achieving good results. Illinois, Missouri, Arizona, Colorado, and Washington have all lowered medical costs, have all increased access by integrating care, primarily through their Medicaid programs, a terrific place to start. They also improved healthcare outcomes, which of course is the ultimate goal of this exercise, and reported increased access to care, reduced hospitalizations, and improved management of diabetes and hypertension and other chronic illnesses. In our first panel today, both Anita and Kenna are going to share with us their personal experiences in navigating this very complicated healthcare system, both before COVID-19 as well as during the course of COVID-19. Unfortunately, their stories, as you will find, are not unique to them nor to their families. There has been difficulty in finding an opportunity for diagnosis and increased opportunity in securing the kind of mental health treatment that they were seeking. And even when treatment was within reach, there are sometimes long waits because of issues with respect to workforce and other challenges. They may be out of insurance, the ability to finance these services are all issues that families in this country face. So we're going to begin with them and have us talk about essentially what they experienced. When a person has a mental health condition, it often affects their entire family, as we well know. It essentially exposes the family to challenges. It could have essentially confronted them in a variety of different ways. But Anita is going to talk with us about her mother's story and essentially about their journey together and essentially how they managed through this unique and difficult time. Anita, over to you.
Yes, thanks, Sheila. And thank you for the Bipartisan Policy Center for giving me the opportunity on the platform to share this story. And so I'm going to talk about my mother. So my mother is a Latin immigrant from the Dominican Republic. She has lived with serious mental illness for over 30 years. And until recently, she was receiving her mental health care through her primary care doctor. And even though her primary care doctor and office did not have mental health expertise or care coordination services, she kept going to the primary care doctor to get her mental health care because she had an established relationship with him. He spoke Spanish, his staff spoke Spanish, and that was important to her. And this is pretty common for people of color, especially those who have unique cultural and language needs. They often prefer to get their healthcare needs met at the primary care office. Now, we all know it's hard to find mental health care providers. Now, imagine trying to find a mental health care provider who speaks your language or at least understands your culture and where you're coming from. So unfortunately, about a year and a half ago, as a result of our separate mental health and physical health system, my mother fell through the cracks. She stopped going to her primary care doctor and as a result, stopped taking her medication. And this led to a 2-week hospitalization. And so often in the healthcare policy world, we talk a lot about how expensive hospitalizations are, but we don't talk enough about how much of a toll they take on families. And so for us, what this looked like was a lot of angst, uncertainty, but a real sense of physical separation. When my mother was hospitalized, I couldn't text her or call her in the same way because they remove a lot of your personal belongings, including your cell phone during psychiatric intake. And so it was tough on us. The good news is that as a result of her hospitalization, she was linked to a psychiatrist, a licensed clinical social worker, a nurse practitioner, and a care coordinator, all of whom speak Spanish and all of whom are on the same electronic health system. And now as a result, her care is more integrated. And the difference is like night and day. So she is way more engaged in her care. Her providers are all on the same page. They understand her, they're able to work with her and keep me in the loop as well. And so as a result of my mom taking a more direct role in her care, I'm able to take a step back as a caregiver and play a more supportive role, and which allows me to focus on my personal life here in DC and not to have to be sort of always navigating her care so directly. And so I think there's an important lesson here. My mother should have had integrated care from the very beginning, whether she wanted to get that care from her primary care doctor, where she felt comfortable, or have that care primarily through her psychiatrist. The key is to have integrated, culturally competent care, because that's what works for individuals who have mental health needs, and that's what works for the family members who are supporting their mental health care journey.
Terrific, thank you very much. Anita points out a couple of important critical facts that we didn't touch on in our initial comments. One, there's also the paucity of providers, but there are also the cultural challenges that families face, language barriers that are complicated even further in a psychiatric situation. So again, these are some of the issues that we tried to take into consideration when looking at the recommendations we put forward. But let me now turn to Kenna. Kenna similarly has a personal story about navigating the barriers, and I'm hoping that she will share with us some of those barriers are and essentially how best to navigate those challenges. Kenna, over to you.
The biggest roadblocks that I faced were finding a therapist, cost, and cultural competency. At my university, I have encountered so many students who struggled with long wait times of over 1 or 2 months and were ultimately referred off campus after a couple of semesters of support simply because the universities didn't really have the capacity to support them. With off-campus services, the difficulty lay in transportation and cost. Since most of us do not have cars and the cost of services in the DC area where I went to college was from $100 to $300 per session. As most of us college students were surviving off mac and cheese and macaroni and noodles, we just had difficulty in prioritizing our mental health and other needs. And yet we cannot afford not to. I've had many friends who unfortunately were forced to take medical leave or put on academic probation or dropped out or were forcibly hospitalized. These results could have been avoided if we had access to consistent, affordable, and culturally appropriate mental health support. Students of color and children of immigrants may have an even more difficult time at finding therapists who are culturally competent. Mental health is a taboo topic in many marginalized communities, and yet racial trauma definitely impacts mental health. Additionally, it's nearly impossible to talk about mental health in immigrant communities when there's this expectation of achieving success to give back to the family for their sacrifices, as well as the idea that children of immigrants will never have difficulties on par of that with their parents who were refugees, for example. When we talk about college mental health, there is also an expectation that parents are involved in helping the youth navigate the complex insurance and health systems. However, that is not possible if the parents themselves have limited knowledge in the health system or when mental health is a cultural taboo. It is vital to have therapists who understand these cultural dynamics and are able to support clients with these backgrounds, especially in light of recent events. We've spent time and energy as a country telling people to seek help when they need it, which is important. But it's not enough to tell people that they should get help. Help needs to exist and be accessible.
Terrific, thank you. I want to go back to one of the other discussion items, and that is the question of workforce. We know that there are a shortage of providers available across the spectrum in terms of physicians, nurse practitioners, social workers, and others. Ken, I wonder if you might comment on that question in particular, and that is, we don't have nearly enough providers. You are a peer supporter, you have functioned in that capacity, and I wondered what your experience is and what you think we can do to support the gaps or filling those gaps in terms of treatment opportunities.
Great question, Sheila. So just to start off, I want to define what peer supporters are. Peer supporters are people with lived experience of mental health conditions who are trained to provide support to other individuals with mental health conditions. I ran Project Lighthouse, which is an online platform that provided anonymous peer support. Our work included providing emotional support, basic education about positive coping mechanisms, and information on how to navigate our complex mental health system. In the last decade, we've definitely seen trends that indicate more and more students are utilizing mental health services. However, many universities across the nation are unable to meet the growing need. The purpose of Project Lighthouse was to provide additional support and shift the task of basic emotional support from counselors to peer supporters so that counselors were not so overwhelmed, and more importantly, students were able to receive the support that they needed at the moment that they needed it. Variations of this model should continue to be replicated outside of the college setting. Peer support provides a model of what healing can look like. It becomes easier to believe that your mental health can improve when your support team includes people who have gone through the same mental health difficulties that you have, or have a similar cultural background. This could increase adherence to treatment. The peer support relationship also shifts away from the power dynamics that could exist between a person with lived experience and their therapist. Finally, research shows that peer support is effective in improving the wellness of the peer supporter, who is also a person with lived experience. Although peer support is relatively new, it has an important role within the space of mental health. We don't have the workforce bandwidth, especially with the rise of mental health needs due to the impacts of COVID-19. As such, peer support is a critical service.
Terrific. You've raised a number of important questions. One, who makes up the workforce, how to augment that workforce with different and less traditional providers, and the sort of unique set of circumstances for people who in fact do come with lived experience, and the opportunity to draw on that experience. Let me turn now quickly to Anita for the last question that I'm hoping we can talk about before transitioning to our larger panel. Anita, telehealth, which we've seen grow dramatically in the course of COVID, is certainly providing an opportunity for many who are seeking mental health services that are delivered through that method. How has it worked? What's your been impression about the opportunities that telehealth has provided? And essentially, do we think we're going to continue to use those services post-COVID, when we're back in a more traditional sort of go into the office kind of environment? What role will telehealth play, and what experience have you had in its use and the value that it provided, and whether it was a positive experience?
Yeah, that's a really important question. I think it relates really well with what Kenna just said about peer support, right? That peer support is about increasing access and increasing engagement. And I think that telehealth can also be about increasing access and increasing engagement. And so my mother has, like so many of us, had her care go virtual as a result of the pandemic. And so since last March, she's had every single appointment through the telephone. So appointments with her psychiatrist and nurse practitioner. So all of her psychiatric and primary care appointments. And so even though my mother lives in New York City, where there are thankfully many providers, it still would take her up to 3 buses to get to her appointments. And as a result, she was missing her appointments. But since her care has gone virtual, she hasn't missed a single appointment. And she not only is not missing her appointments, but has now started participating in group therapy over the phone in Spanish. So once a week, she meets with this group, and they all sort of talk about how they're feeling, and especially given the pandemic, the sort of issues that they're facing that week. And this has been a really important support system for her, and not something she would have ever engaged with if she didn't have the option of doing so virtually. And so one other thing that I would like to mention is that as a result of my mother's symptoms, she has had in the past some fears with and hesitations with using video. And so it really wouldn't have been a very viable option for her. And she really embraced these audio only sessions and these telephone sessions, and really hopes to continue to do so after the pandemic, so she can continue receiving the care that she needs in a way that minimizes her travel costs and time.
Thank you, Anita. I'm going to close up this session, but let me note that the issue of telehealth is one the Congress is certainly considering, when the agencies are considering questions about its use, how best it's structured, whether in fact it's video, whether in fact it's audio only. So these are questions that warrant serious consideration. The administration has moved towards continuing the opportunity to use those services under the federal payment systems. But again, I think the example you used, Anita, in terms of the different methods, it isn't just video, that it really is a variety of opportunities to connect with folks. So let me end by thanking both of you for sharing your very personal experiences that help us understand the challenges that are being faced, and also give us the opportunity to look at some of the solutions going forward. So my thanks to both Anita and to Kenna for sharing that.
Thank you.
I now want to turn to our broad group. Billy mentioned at the outset that we had just a remarkable group of people that were involved with the task force who lent themselves to this consideration and these discussions, and brought with them personal experiences, brought with them sort of a unique perspective of how they've experienced these questions and challenges. It was a remarkable year, and I know I join Billy in thanking everyone for the time spent and for the remarkable work of the staff as well in pulling the report together. One of our major goals was, in fact, make it more feasible for primary care providers to deliver services of a behavioral health nature to patients. That is, but for patients that are experiencing mild and moderate sets of conditions. We believe we can do that by providing them with additional support, with technical assistance, with compensation, as well, to encourage them to look at that opportunity in taking care of their patients. And while some now deliver both physical as well as behavioral health to their patients, many of them feel ill-equipped to do so. And one of the questions we examined was, what can we in fact do to provide more support and more assistance in giving them the tools necessary? It means making behavioral health providers available to primary care providers for consultation, for coordination, for referral of treatment. And to address this, we looked at the current behavioral health workforce and looked at essentially accessibility, where that was available, where it wasn't, and what the barriers were to doing that. Looking at issues around network adequacy and possibly tightening those and making sure that networks, in fact, include a broad array of providers. We looked at essentially ensuring that those that were in networks actually had time available to them, actually had opportunities. Simply listing a name, but then when someone calls to get a reference or in fact schedule, to find that they are completely booked or not available provides little assistance. So part of the challenge was both including them and making sure that they were willing and available to participate. So we're going to talk about those issues. My panel are going to reflect on some of our recommendations, why we got where we got, and what we think are most critical in sort of looking forward. I'm going to begin with Patrick Kennedy, if I might, who was enormously important throughout all of our discussions. We've talked about what happens to people's health during the pandemic, why it was uniquely challenged, record rates of depression, anxiety, many of the issues that Billy raised, drug overdoses and suicide, and juxtaposition that with a growing number of really treatment gap, sort of a growing treatment gap that sort of occurred as well during this period of time. We see the percent of adults with mental health conditions receiving treatment actually decreasing rather than increasing during this challenging period of time. Less than half the adults with mental health conditions receive treatment, which is a startling number, and the gap got even bigger in 2020. So I wonder, Congressman, if you could tell us about that. Tell us what we know about that reality.
Well, thank you so much, Sheila. It's really shocking that our life expectancy as a nation is now dipping down, even while cancer survival rates are improving, thanks to the great war on cancer and all the trillions, let me repeat that, trillions of dollars that we spent on that, which, by the way, no one questioned. And thank God, because my family, everybody's had cancer, and I know we benefited from all those early dollars. Look at the fact that there's 90% survival rate from childhood leukemia. Look at the fact that over the last 2 decades, we've seen steadily decrease in fatalities to heart disease every year. At the same time, we're seeing marked increases in not only depression and anxiety and addiction, but the ultimate of that, and that is the increases in suicide and overdose. It's pretty shocking when you look at these statistics that we don't place the same value on the health of Americans when it comes to their mental health as we do with the rest of their physical health. And that's really why I'm so honored to be part of this bipartisan policy group that's setting forth some recommendations that, just like when we were in Congress and Senator Domenici worked with my father, and I worked with Jim Ramstad over in the House, along with many other of my colleagues, and we got the bill done with George Bush signing the bill into law. And that federal law, frankly, has not been fully implemented. So part of our recommendations are not only to fully implement the law, the Mental Health Parity and Addiction Equity Act, which says categorically inpatient in-network, outpatient in-network, inpatient out-of-network, outpatient out-of-network, pharmacy and emergency room benefits, that they must be on par with what we'd expect from oncology and cardiovascular disease and diabetes. And not only that, but our report now also calls for greater oversight and transparency with payers, including and especially the federal government with CMS, to show network adequacy levels, so that to address the previous concerns with people not being able to find a therapist, of course, having to go out of network, which is what happens to most Americans, where they pay more for care that they should have been able to be provided in network. And then, of course, to have among those very finite number of mental health professionals, those that are also culturally competent. So we have a massive challenge. And what I really appreciate in this report is that it's focused on specific levers, both on the regulatory level and statutory level, to enhance the access and affordability of getting mental health, knowing that it is a major public health crisis, irrespective of COVID. But certainly with COVID, it's now going to be with us even more powerfully in the years ahead. And it's something that we need to dramatically increase our capacity in order to meet. And so we've repurposed our current medical system to also engage in this, because as you know, for too long, we have marginalized mental health and addiction to the periphery of medicine, as opposed to making the House of Medicine acknowledge that part of medicine is also dealing with mental health issues. And I think those are that integrated care model, the value-based purchasing model, all of those that are recommended in this report do a lot to add to the previous success that we had when we passed the Mental Health Parity and Addiction Equity Act.
Thank you. One of the things you mentioned that I'm hoping Richard can talk with us a bit about, and that is the movement, as you suggest, towards value-based systems and those organizations, and whether or not that, in fact, moves us in the right direction. It's an issue that the task force, in fact, did address. And I'm going to ask Richard to talk with us about what we know about those value-based organizations, the incentive systems, and whether or not they are a critical element and can move us towards a more integrated system. But Richard, your thoughts on the use of the value-based programs and what incentives they might provide, and the recommendations of the group.
Sure. Thanks, Sheila. And I too want to thank the BPC for putting together this task force. It's actually been a great experience for me. Let's start at the beginning. Integration means ensuring that behavioral health care and other medical care work together on behalf of patients and to get the best outcomes. And clinical science has shown us that when this is done and done properly, it's extremely cost effective. There have been over 30 studies that have shown, consistently randomized trials results in cost-effective treatment for behavioral health care in primary care or in specialty care when primary care is brought into those settings. Now, our public programs are moving towards payment and accountability for population-based care and population health. Integration plays very consistently with that. That is that when you manage the care of a population, you have considerable flexibility in bringing medical care and behavioral health care resources to the fore on behalf of patients. And so what you see is bringing behavioral health care into the mainstream of general payment systems, our insurance programs, and making it a standard part of healthcare. So making integration work within these payment systems means that it's a critical way to promote those systems really adopting what we've learned from clinical science to make the outcomes for patients overall stronger. And it is really in that spirit that our recommendations were really pushing forward the idea that bringing behavioral health care into the mainstream, making it a part of all of healthcare is the way to improve both the efficiency and the outcomes of care.
Richard, let me just follow up if I might. One of the things in particular the task force has recommended is financial incentives and using the existing models, the MCO models, the MA models, and ACOs. There was some discussion about fee for service. And I wonder if you want to comment at all about the focus that the task force placed on the Medicaid MCOs, on the Medicare program, and the MA plans to begin, rather than widely try and direct the entirety of the program. If you want to comment at all on that, because that was certainly something on which we spent a fair amount of time.
Yes. What we've seen now in the Medicaid managed care organizations, in the Medicare Advantage program, and in the Medicare Shared Savings Program, or ACOs, is that emphasis on population management of both care and of their health outcomes. And what those programs each do is they give insurers a lot of flexibility in how they structure and manage the care for individuals, which allows them to assemble the resources that are necessary to deal with advancing the health of their enrolled populations. And that means combining all the different elements of care. And with that flexibility and with the incentives to do well on full person health, that encourages greater attention to integration of behavioral health into the general medical system.
And I would assume that the nature of those arrangements, where you have a variety of providers connected through those systems, also provides a greater opportunity for that integration, rather than the one-off who has the challenge of trying to figure out what the network is. So the organization and the financial incentives, I would assume, would also work in favor of essentially a better coordination of care. I want to turn to the challenges being faced by providers. We've noted that individual physicians, nurse practitioners, and others who are primary care providers often have difficulty navigating this or finding partners to assist them in that. And I wanted to ask Dr. Benjamin to share with us sort of her impressions of the unique set of challenges that are faced by primary care providers and working towards behavioral health integration, the availability of the workforce, the availability of those connections, and essentially how she's experienced the challenge of trying to meet those behavioral health needs. And if we're going to ask primary care providers to take on more behavioral health care, what is it we need to do to support them?
So there's so many things we need to do, and I'll answer that part first. Is as doctors, we all want to do good, and we want to do good for our patients. You know, I'm a family physician, and as was said earlier, much of our practice is dealing with anxiety, depression, everyday stress. Those are as important as the physical things that I treat, like blood pressure, heart disease. But what we have is a problem in that we are not always comfortable there. Our report is recommending that we increase the grant funding for like statewide psychiatric consultation services, for example, to provide primary care clinicians with behavioral expertise to treat mild to moderate conditions. So many of us don't feel that comfortable because we're treating patients, particularly with behavioral and substance use needs, especially when they are much more complex than we feel like we're comfortable handling. So if we can enter this, you know, when we come into the workforce, we are not used to working into integrated teams. And so increasing the funding to help continue our medical education, continue our programs, clinicians will help. And giving us an opportunity to consult with behavioral health providers. And that's, you know, with our recommendation is that whether it's on site with a mental health worker or a remote psychiatrist that's, you know, actually available to us, we need to feel like we're comfortable being able to just reach out to them. We can fill in those gaps and receive that real-time consultation right there. What I've noticed with in some of our conversations is that we all have a clinician inside a primary care office, and we can have a psychiatrist there on site. We can have a mental health worker or a social worker. That actually gives that warm handoff, or if we have it remotely. The other thing we can do is provide some technical assistance to our primary care practices. Transforming a practice into this type of model really takes time, and it takes a lot of effort and upfront investment. So we can give that technical assistance and greatly improve the care and the workflow. Technical assistance can help us identify what the needs are and help us with the billing and the training. and it can incentivize us to do more. You mentioned about how do we increase and handle that increase in demand. Working on site together, as I mentioned, many of the community health centers and the certified community behavioral health centers work together, having those behavioral health specialists and specialties right there in the office, where I can walk down the hall, tell them I have a patient, introduce them, not having to wait weeks for an appointment somewhere across town. In many rural communities, you don't have another behavioral health professional there, or you can do it through the electronic way I was mentioning but they have to be available for us, and just that peer support. The certified peer support specialist that we just heard about is so important. It's important when it comes to having that culturally available, competent individuals who can help us with this integrated care, help us navigate the patients through it, give patients that trust that they need within this system, particularly when they haven't had that. The other thing I want to just make sure I mention is that we can diversify our workforce, and peer supporters is one of those, but also it helps decrease the barriers to access to care, like language barriers and that comfort level. Encouraging and supporting funding partnerships between medical schools and local organizations to get this pipeline going to recruit students and from underserved and underrepresented populations. And I know that we talk about the mental health and behavioral health. So oftentimes you think about the cities and things, but don't forget about the rural areas where we don't have those resources. There are many more primary care offices in this country than we have mental health facilities. So when you can merge them together, have a holistic approach to primary care, it would help the doctors, the clinicians, and particularly improve the care that the patient gets and the outcomes.
Thank you, Regina. I want to note that, in fact, the recommendations include possibly a capitated payment. There's been a question raised in the chat room about how to assist small practices. I mean, it's one thing for a large integrated system. It's another for a relatively small practice in a local area, particularly in rural areas, as Regina points out, where there's an extraordinary shortage. I spent a fair amount of time in the state of Kansas, working for Senator Dole for a long period of time. And the paucity of services and clinics available in those rural areas is remarkable. So again, there's capitation that we're envisioning for primary care providers to assist them. So we try to address a number of these questions in the course of the report, recognizing that there are serious issues there. Regina,
I would add that in addition to the capitation or the value-based care, which incentivizes me as a primary care doctor to look at the patient as a whole person, as a whole outcome, not just as an encounter. That helps, but also, as we mentioned, helping the small practices increase their continuing education, finding ways to integrate, particularly that EHR, that electronic record for the behavioral health is so different than for the primary care. They don't talk to each other. They're just two different systems. We have to bring that together, and small practices can't really afford that. So we need to give them a way that they can actually move to that investment, anything to incentivize them. The telehealth is important because, again, patients they need access to care, and they get that access. And it was mentioned earlier about the different types of telehealth. The telephone, particularly, many people have cell phones, and we know they have cell phones and don't have landlines, but in many rural areas, all they have is a landline. And so we have to get to where patients are and have them increase access to care. So
Kennedy, I sense that you'd like to comment on this as well, in terms of the challenges for small practices and supporting primary care providers in that world.
Well, I think Surgeon General Benjamin really pointed out the disparities. So, we in Congress subsidize meaningful use for the rest of healthcare. I mean, this is paid for everything else, but we have not subsidized the connection of this medical treatment for those with mental health with the rest of their medical treatment. It really is a structural barrier. And in our report, we try to identify not just those financing mechanisms, which we just spoke about, but those structural barriers. And let me just add, after the public health emergency is over, it's really incumbent upon Congress to take some of these telehealth opportunities that were really made available because of the blanket public health emergency status, and then codify those going forward. And that's one of the reasons why these recommendations are so timely, because we need to be prepared for that day when it comes.
I'm going to turn to Governor Sununu or Senator Sununu, sorry, Senator Sununu in just a moment, to talk a little bit more about telehealth. But one of the questions that we've had come in that I'd like all of your comments on is as mental health and substance abuse services are integrated, the question asked by Kate is how does that impact the Mental Health and Parity Addiction Equity Act and the implementation efforts? Is it consistent? Is it a different direction, different set of challenges? I mean, how does one think about it in the context of essentially the work done with the Parity Act?
Well, I might just jump in quickly. So, no doubt, if you were to spend dollars that are going to produce the greatest return on total cost of care, it's hard for me to believe that you wouldn't be spending them in mental health. And in that case, as an advocate, I wouldn't want to put a cap on them. I wouldn't want to be held to whatever we're paying for in terms of the rest of medical care. We should be paying more, frankly, if we want to really see the benefits of cardiovascular disease care, where we know people are 4 times more likely to die of a heart attack if they've got underlying depression, or trying to deal with alcoholism when someone has diabetes, and so forth and so on. My sister had cancer, never was given depression treatment. Who gets a diagnosis like that and isn't traumatized? So I think as we move to this, I think the value will make the case for mental health. But that said, we do need to obviously modernize what our metrics are for holding insurance companies more accountable to the premise that they need to show the same urgency. Okay. And it may not be in the old ways that we wrote it in the original law. It may need to be done in new ways. And that's among those things that we were thinking about in this report when we talked about strengthening network adequacy. So that's not just simply about transparency and non-quantitative treatment limits, but now we're going to be insisting on more accountability in other ways that show whether that commitment is there by payers or whether it's just talk and no action.
Richard, I know you've spent a tremendous amount of time looking at the parity legislation and looking at the implementation of parity and our failure to achieve the results that we hoped we'd achieve at the outset. Anything you want to suggest in the context of what we're suggesting here, how that's going to move that ball forward, and how we have to think differently about how to measure, as Congressman Kennedy has suggested?
Yeah, I think there's 2 things to remember as we think about how parity applies here. The first is the good news, the progress we've made, which is previously the care delivered by primary care doctors and specialty clinicians was often distorted because of the way the benefit designs were unevenly structured, so that it was more costly for somebody to get therapy out of pocket than it was to, for example, just get medication or something. This balances things so that a primary care doc can use all their tools to treat a patient and not be worried about saddling their patient with undue financial burdens. So that's the good news. The other thing that the parity law did was it started putting some rules around how we manage care. And it's that's been incompletely implemented. And I think that's what Congressman Kennedy was referring to. And it's really that very challenging problem that needs to be addressed both on the primary care side, but also on the specialty side. Just how do insurers and other organizations really even-handedly manage the care? And I think that Congressman Kennedy was just right, that we need to sort of modernize our accountability systems to get there. And that's really going to be the next chapter of parity.
Great, thank you, Richard. Senator Sununu, we've referenced on a couple of occasions some of the issues with respect to telehealth, but we haven't really talked about the broad questions of information and information transfer and the access to information. The integration, as described by all of you, is critical to be able to access that information across the board so that there are no barriers in terms of sharing. Many of the behavioral health providers, particularly those in small settings, don't have the resources, don't have perhaps the tools available to them for information sharing. The HITECH Act authorized $27 billion, as I recall, to increase essentially the utilization of electronic health records, but excluded behavioral health providers. What are we suggesting? How are we thinking about this technology question and how critical it is to this integration effort?
Sure. So there are two parts, at least two parts to the problem. One is the data issue you mentioned with the electronic health records, the EHRs. I mean, much more could be done to make sure that the EHR template is compatible and supportive of the behavioral health setting, even, you know, going so far as to make sure you have standard and common behavioral health terminology as part of that EHR. The barrier for the small providers, though, very real. Even for a small provider to implement healthcare IT and an EHR system can be $40,000 or $50,000 in upfront costs. And of course, there's maintenance, you know, annual costs, $10,000, $15,000, again, even for that small provider. So one of our recommendations is to make sure we have a financing mechanism to help access that kind of technology for the small providers and help use that technology, obviously, to deliver integrated behavioral health care with primary health care. So that's structured as we've recommended in a forgivable loan. In fact, it's one of the things that we work most aggressively and closely with Nella Domenici, who was one of our task force members that you mentioned in your introduction. So that's the mechanism for the smaller providers to help access technology and integrate the behavioral health care. We also discussed at length in the report telehealth, and you raised the issue earlier of some of the obstacles to telehealth. Look, even before the pandemic, this is an industry that was growing. There was a great deal of enthusiasm around utilization of telehealth. I think the forecasts were pre-pandemic for telehealth to grow 20 or 30% per year over the next 5 years. Obviously, the pandemic changed that dramatically. And it's almost hard to believe the types of growth that we've seen in the industry or utilization. I think by one measure, in April 2020, telehealth visits were up 4,000% over April 2019. Now, one of the reasons for that was mentioned there with the public health emergency. There was an elimination of many of the barriers that already existed to utilizing telehealth. And I think one of the most important sets of recommendations we have is to make sure that there aren't barriers that are re-erected. I mean, the way government works with a new technology all too often is that regulators are worried about its uptake, its utilization, its cost, its impact. But this is a case where, because of the pandemic, we have shown and been able to show the efficacy, the efficiency, the way it improves provider utilization, the way it improves, comfort and safety of patients. And I think that creates a huge opportunity to build on this momentum. So the kinds of restrictions that we talk about in the report are, for example, geographic restrictions. There are restrictions that require a utilizer, a patient that utilizes telehealth, to be in a rural area. There are requirements that say you have to have an in-person, face-to-face visit first. There are requirements that say you have to maintain a certain frequency of in-person visits. There are requirements that say it can only be a video-to-video link. And we heard earlier panelists talk about the value of the audio link. We've all been on Zoom calls over the past year, where some people are on video and some people are on audio. That doesn't make it any less effective. So what we recommend is eliminating those site of service requirements, the geographic requirements. And on the provider side, there are provider requirements that the provider cannot be in a rural health clinic. The provider cannot be in a federally qualified health center. We recommend eliminating those restrictions as well. Again, this comes back to opportunity and momentum behind the utilization of telehealth. It's a format and a technology that lends itself to integration of behavioral health care and primary health care, because you can have different providers in different locations. You can easily make referrals. It saves so much time on the part of the patient, so that if they have to go from work with both behavioral and primary health care, they can easily access both. And then I mentioned the video to video requirement. We recommend eliminating that. There are a lot of elderly citizens that aren't necessarily comfortable with the video link, or as was mentioned by Dr. Benjamin, not everyone has access to high-speed broadband. It might be a landline, it might even be a cell phone, but the ability to deliver quality integrated care through these technical devices is no less. So I think it's an exciting set of recommendations, but now's the time to do it. If we make the mistake of reimposing these restrictions, I think we'll really stifle the innovation and the acceptance of telehealth that we've seen over the past several months.
So Sheila, can I add on to that?
Yes,
In addition to just simple common sense, it improves the access to care. Many of the patients don't want to necessarily come in, so they have a better access. But our report also recommends that we permanently cover Medicare and insurers permanently cover telehealth services. But we also bear in mind that we want to make sure we maintain the privacy for the patient. That's an important part, that we're not gonna, we didn't forget that part. But telehealth also helps to decrease some of that stigma. People still have this stigma about coming into the office. And when you have a primary care and a behavioral health working together, people will come in because you don't know if you're coming in for your blood pressure or for your anxiety or your depression. So that stigma is decreased with that as well.
Senator Simonu, I wanted to come back to you for just a moment. I mean, you are having come from a rural state with all of the challenges of rural access to services, a limited number of providers. One of the questions which we touched on only briefly is, how do we think about educating providers differently? How do we think about how we recruit so that providers look like the people they are serving? And I wonder, having thought about this issue from a relatively small state, relatively limited circumstances, how we think about those issues, how we think about recruitment, how we think about training, how we think about creating opportunities for providers to begin to associate themselves with others with whom they may not have had a conversation. And I wondered, given the sort of unique challenges in a state like New Hampshire, how you think about that.
Sure. Well, I mean, I think, New Hampshire certainly has rural areas, but, we're not, it's not like Wyoming or Montana or some of the Western states where rural means a different thing in those states than it does in New Hampshire. We're a diverse state, but of the things you mentioned, I think training is the one thing that's important and essential and applies across a broad range. I think, there are ways and opportunities to ensure that we incorporate, one, the idea of integrated care, integrating behavioral health care with primary health care. And I think that goes back to our medical schools, to our federal support for graduate medical education through the JME program, support for nursing through the nursing grant programs. All of those are tools and mechanisms that the federal government has to encourage a holistic approach to integrated care. On telehealth, though, I come back to the opportunity to build on the momentum that we've seen, and there's a tremendous amount of applicability there to a state like New Hampshire that, again, is this sort of mix of rural and suburban. But I think about an institution like Dartmouth-Hitchcock, one of the outstanding oncology and cancer centers in America. But at the same time, there are people even in New Hampshire who might live in a more rural area. They might be 2 or 3 or 4 hours from that center, but still certainly would be afforded a better opportunity to take advantage of the facility if we had better access to telehealth. Someone raised the issue of the providers. From the provider perspective, it's much better utilization for them, efficiency for them, and their ability to see multiple patients from different areas over a tighter and more efficient allotment of time. So there are patient benefits and savings of time and money, but provider efficiency and utilization benefits as well. And the last thing I would mention there is just to underscore the value that's already been demonstrated in the behavioral health healthcare side. Behavioral health utilization of telehealth was, again, pre-pandemic, significantly higher than primary care utilization. And I think that experience and utilization level on the behavioral health side should facilitate the better integration with behavioral health if we eliminate these barriers to telehealth implementation.
It's interesting. One of the questions that we got in the comment box was about this question of efficiency, and the point that was made from YouTube was that while telehealth is convenient for patients, what considerations have to be taken into consideration about whether or not providers are reaching their maximum efficiency in using that tool? Whether it, in fact, to your point, in fact, provides them a greater opportunity to be efficient, utilizing their time differently in the context of utilizing telehealth. So your point's exactly on that question, which is, does it make them more efficient? Let me ask.
Can I just add to that a little bit? And it was also asked about fraud if you're doing audio calls. Well, if you're paying me on a value-based system, then you're paying me for outcomes. You're paying me to make sure that I deliver good outcomes. And so it won't matter if I'm getting one fee. If I have one call or 100 calls, I'm not paid per call. So I'm paid to make sure that patient is better. And so I think this whole system would be much more efficient.
Well, it certainly recommends starting away from the fee-for-service model, where it is do something, get something, and doing it in an integrated way.
Let me just also point out, Sheila, that you asked about quality, because one of the challenges are that even those with the behavioral health certification are not always practicing the evidence-based treatment for a particular diagnosis, that they're treating because we have a current one-size-fits-all system for all behavioral health providers. You put a shingle up and you're treating eating disorders in the morning, depression in the afternoon, and depression and grief counseling at night. We need to bring much more fidelity to the best treatment models. And I think that skill-based approach and uptick of training not only applies to where you would assume it would, and that's the general medical profession that has basically got very little of it in their medical education, but it also needs to apply to those with mental health, who are mental health clinicians out there, because the end of this is not only more access, but access to quality treatment. And so a lot of what our recommendations are in terms of training go to that whole point, because we need to increase effective quality treatment while we're paying for it. We don't want just like someone being able to outsource this halfway across the world and some concierge therapist that can talk to you in the middle of the night. That's great, but what are they saying to you? How are they conducting themselves? Are they doing it in the context of a medical protocol that shows and demonstrated effectiveness?
One of the other issues that came up, and we have just a few moments left, so I won't ask us to spend a great deal of time, but there was an issue that came up with respect to the ability of providers to practice across state lines, and what limitations there were. And it came up in the context, in particular, interestingly enough, about a college student who'd gone home from college, but their provider couldn't access them because they were in different states. And I know one of the issues that's come up in the context of the pandemic is this question of how easy or how difficult is it for a provider to essentially provide services across the state line. And I know, Senator Sununu, this is an issue that you've talked about. Certainly Congressman Kennedy, you have as well. Regina touched on, Richard's talked on, we've all talked about where are those barriers and the balance between fed and state, because the state licensure laws and the states really drive that question. There are compacts, but I think this is also something we touched on, but didn't come forward with a strong recommendation, certainly not a federal preemption, but it's certainly something we talked about, that there are limits and the inability of people, particularly given challenges in a situation like the pandemic, of being able to access services outside of their state, particularly across state lines. So
in the licensing board arena, we've really worked really hard to try to work on this. And it's a challenge because every state has its own medical practice act, and we're doing everything that we can. We do need some sort of federal help with that, I think.
But again, the group clearly decided not to do a federal preemption,
Right.
but to examine this question as one of the issues going forward. We have 2 minutes left. Let me ask the panel if any of them have any final notes, comments, things that we haven't touched on. I mean, the report is quite dense and covers a whole host of areas, some of which we didn't touch on today. But each of you, a couple of minutes of final comments. Governor, or I'm going to continue to do that, Senator. I'm sorry, Senator Sununu. Any final comments?
Well, I definitely want to thank the staff. I mean, we have 4 panelists here. You had 2 a bit earlier, but I mean, there was a large group of staff at BPC that did great work and great research. We have a great number of recommendations, but the fact is there was a lot of work and a lot of recommendations we chose not to put in the package. I mean, I think we did a good job of creating a framework of recommendations that can attract bipartisan support. At the end of the day, that's the real value here, is providing substance for legislators to take. They're not going to adopt every recommendation, and those that they might adopt will probably be tweaked or negotiated, but it's a great framework, and I give a lot of credit to the BPC and their staff for helping us through the process. Thank you.
Thank you. Congressman?
Well, I'd say in Congress, I associate myself with the gentleman from New Hampshire. He said it right, in acknowledging all the tremendous staff time and expertise that went into building out this report. I would add one thing that we really didn't dive into too much, and that is we've got a whole lot of new money coming in through America's Recovery Act But let's be honest, that is very much discretionary dollars or in block grants. What we're really recommending is that we build a sustainable, reimbursable system where people are not going to run out of money 2/3 of the way through the year. And unfortunately, we don't spend money in mental health, but for a large part in these block grants. And they're good for training and they're good for the capacity building. But in terms of long-term sustainability, we've got to go to these broader health insurance reforms that we've proposed in this report.
Great. Thank you. Dr. Benjamin, final comments.
Yes, I'd just like to ask those folks who are watching to just help us and join us in trying to get our healthcare system to put physical health and mental health back together again and on equal parity. It'll make us a much better and healthier nation.
And my friend and colleague, Dr. Frank, final comments, observations.
Thank you. Well, first of all, thank you to the task force members. They've been a great group of people to work with, and I think we've done productive work. I'd just like to go back to the beginning and say that we are never going to meet the needs of the nation's mental health without active and deep participation by primary care providers. We will not sort of specialize our way out of this. And so the good news is that we know how to do this. There's a lot of science behind it, and it's a really good deal. And so we should build on that part of it.
Great. So let me thank all of the panelists that joined us today, and also thank the staff who really did just remarkable work translating all of the work that we did into something that is coherent and again, I think touches on just a host of issues that we've not had a full opportunity to discuss. But I would encourage folks to take a look at the report. This is a wonderful opportunity. There are resources flowing. And I think to Congressman Kennedy's point, we're really looking for a sustainable solution, not simply a spot check on particular issues, but rather how do we build this into the system so that essentially we don't see 2 years, 3 years, 4 years from now, another crisis where essentially we recognize once again the absence of the services that are needed. So let me say thank you, and let me turn it back over to Billy to finish us off. And to thank all of you who've joined us in the course of our conversation today.
Thank you. Thank you, Sheila. Thank you. Thank you, panelists. Thank you all. We're over time here, so I appreciate it. Go to our website if you need a copy of the report. Thank you.
Thank you.